We are now ready to start, and again, it is my pleasure to introduce today's session on this Precision Medicine Forum in Robotic Surgery, Current Knowledge and Gaps. We've been meeting together for the last couple of days. It was Tuesday. We had a very interesting urology meeting with the, a great presentation with the single port device, and also very interesting review of the current knowledge and the gaps, the future areas of research interest. Yesterday we covered the colorectal topic, mainly around colorectal cancer, and the knowledge or the current knowledge on how to use robotic devices in rectal cancer, in colon cancer. And today it is, I think we are very excited about today. It's a forum on education, training, and how to use different tools, how to measure what we do in education and training in robotic surgery. We have I would say, the honor and pleasure for me to have with us Professor Ahmed Ghazi and Professor Tony Gallagher. Both of them are going to speak about something that they have, I would say, developed themselves. So it is, I would say, a luxury to have the opportunity to listen what they're going to talk from themselves. And for us, Roberto Ballestero is moderating the session together with me. It's I think a pleasure, and it's something we have spoken a lot. We are excited to listen these two, I would say, masters in the topic. So this is the agenda for the day. We will listen first of all physical anatomic models for surgical training, correct knowledge and gaps, from Professor Ahmed Ghazi, and then Professor Anthony Gallagher will speak about Proficiency Based Progression Training, current knowledge and gaps. And we will have a discussion moderated by Roberto Ballestero and myself. We want to thank again the different societies that are endorsing this activity at a national, international level. And of course, again, our sponsor, which is the intuitive surgical distributor in Spain, Avex Excelencia Robotica, who is sponsoring these 3-day activities. So with further delay, I would like to introduce Professor Ahmed Ghazi, and thank you so much, Professor Ghazi, for being with us this morning in the US, and for making this huge effort. We know that we're all busy. It's a challenge to have people from the US and in Europe speaking, and again, it's a big pleasure and honor to have you here. This floor is yours.
Thank you very much, and Professor Gómez, thank you very much for the invitation. This was an excellent forum, and it's truly an honor to present here, but also definitely an honor to be presenting in the same panel with Dr. Gallagher. Like Professor Gómez said, is basically anatomical models. And what we call these models here, or they're now well known as, it's called physical reality, as opposed to virtual reality. And we'll talk about the technology and how we develop it and how we aim to make this the future of advanced surgical training, which is bridging the gap between virtual reality training and actual live procedure. So these are my disclosures. When we look at goals for surgical training, we really start to focus on basic skill simulation, and that's really been something that virtual reality has found a great place to be in. But there are also procedural skill simulation, where you take these basic tasks and then combine them to do part of an actual procedure. We also have crisis management simulation, which something that as a surgical field, as in high stakes industry, we have tended to neglect compared to other high stakes industries. And there's now this new type of simulation known as patient specific simulation, which is a procedural simulation, but it emulates a specific patient. And this is where you use the patient's CT scan to actually make the model. Like I said, virtual reality is definitely taken its place in basic skills training, and it's an excellent tool to do that. They've also developed different curriculums like the FRS, and all the new emerging robotic platforms are also working on virtual reality counterparts for their robots. So this is a very important component of simulation, but it stops at basic training. They have even ventured into procedural training, where you actually get to do parts of the procedure. And the biggest problem with this, although it does teach you how to do the steps of the procedure, and there is some knowledge that is integrated into this, the tissue fidelity is not the same. And also the tissue responsiveness is very different compared to the live surgery. All of us have seen these in our simulations and our various virtual reality simulations, which I like to call the warping effect. And the problem with this is not only is it distorting the way that you handle the instruments, but it is creating this effect with the trainee that this is not real. And therefore, any metrics I get out of this is not really assessing my level of competence. Now, the metrics that are associated with this are truly something that's valuable. They are allowing us to measure the progression of trainees and looking at them passing through this progression up to proficiency. However, these metrics are somewhat difficult for trainees to understand. Things like economy of motion, master workspace range, and etc. makes it difficult for them to understand, how do I apply this, or how is this clinically relevant? So we also wanted to work on something that allows the metrics in our advanced trainers to be somewhat more clinically relevant. We move over to cadavers. Now, cadavers are the best anatomical simulator because they're actually humans. But the problem with that is, although they have all the anatomy, sometimes they do lack the pathology. And one of the common things is, for example, like hysterectomy. Cadavers are not really used in hysterectomy that much because of the rare availability of female cadavers, and most of them have already done a hysterectomy prior to that. But also there are issues with transfer of disease. There are issues with ethical responsibilities and the specialized facilities that are required to house these cadavers. And they also don't bleed except with a very elaborate setup. Animal models are somewhere in the middle. They are perfused. They give that bleeding sense. However, they sometimes lack the procedural elements that are required for us, but they also have ethical issues and specialized facilities that are needed to address. So what we wanted to do, and this is a partial nephrectomy model, you can see that we can use in these models ultrasound. You can do all the steps of the procedure, including clamping of the major renal artery that we do for partial ischemia. And you can see that there's bleeding that is also low pressure bleeding, simulating venous pressure or venous bleeding, but also there are high pressure bleeding points simulating the arterioles that the surgeon would cut through while they are going through this procedure. You can see that there's a difference in the tissue fidelity between the tumor and the kidney, but also if you violate the pelvic calceal system, they will leak urine. One of the major components we wanted to do is make sure that the texture was the same, because there are certain components where the surgeon is exerting pressure on the model, and we want to make sure that we're not training them to overexert this pressure. This is also a great tool that allows surgeons to actually, what we like to call, wander, right? So this is somebody that's doing a partial nephrectomy. They're dissecting the renal artery, and then they neglect to see an accessory artery there, and then there's some bleeding. At this point, they wanted to undock, and I told them, no, this is a great opportunity for you to be able to actually learn how to do an emergency stitch using, a suture with a pledget at the end of it. So they kind of went through those different steps and taught themselves how to do this procedure. So it allows the trainee to go into different planes to explore what they do wrong, because when you tell the trainee, this is the consequence of what you're doing wrong, they tend to understand a little bit better. So how do we make these? We make these using multiple technologies. The biggest one is 3D printing, right? 3D printing is something that's been utilized in surgical education quite significantly, but the result is usually these hard plastic models that don't have the tissue fidelity as required. It is a good anatomical model, but definitely not a good soft tissue model. So what we do is we use 3D printing to create the mold. A mold is a cast, is something that you can inject in or layer things in. And in that mold, we can layer the different elements of the kidney, like the artery, the vein, the pelvic calceal system, and we can even register the tumor in place and in relation to these vessels so that the tumor would bleed when you resect it. So we take these vessels that we also make using a different technique of 3D printing and hydrogel injection, and then we register them inside a kidney mold, which we then inject with a hydrogel that, when processed, then becomes crosslinks and becomes something exactly like a kidney with a massive tumor in it. And all these vessels that you see in urine channels, when connected to fake blood or fake urine, would bleed when you cut through it. I want to start with something that has really been the most common model that has been asked of us, which is the prostatectomy model. That is a very complex procedure where you have to remove the prostate because of cancer while preserving the bladder, preserving these nerves that lead to erection, and avoiding injury of the rectum. So we start with a patient's MRI. that had cancer, and we segment, which is identify every single component of these and bring them together in what we call a CAD. That CAD is then used to develop molds, but there's not only one mold, several molds. So this is the mold for the prostate and the seminal vesicle that forms the prostate and the seminal vesicle complex. We then put that inside a nerve sparing mold to make the nerves. And this is where we can place sensors or place things that allow us to detect the amount of stretch that the surgeon is putting on these delicate nerves while they're preserving them. Then we take the bladder, and the bladder needed to be watertight, and also the surgeon needed to identify the inner mucosal layer to create a competent anastomosis. So we created it in 2 layers and then processed them together. Finally, we also took the pelvis from the patient, 3D printed that, placed soft tissue around it, and this is the actual model, which you can use in your operating room because none of the material used here is cell-based. So it is completely hydrogel-based, and therefore you can use it on regular instruments that you would use on patients. This is an example of the prostatectomy. Of course, it is a very short video just to demonstrate. You can see you can use cautery because it's again water-based material, and our body is water-based, so it does allow us to do that. We've taken attention to things like charring. Surgeons are very visual creatures, so they wanted to see the charring that's happening. So we added something to our base to make that area char when they use the cautery so that they get that same feeling and even the same smell when they're doing the procedure. Anything that is water or fluid contained, like the bladder, will contain water. And then you cut through, and here you can see the layer of the inner mucosa and the outer layer of the bladder. Then we have the seminal vesicle dissection. And here is a good example where we can make different consistencies of soft tissue while also dense fat. And I think one of the good things when people say, you're a master at creating tissue textures, I think we're also very good at creating tissue planes. Now, here is where we go for the pedicle, and this is the bleeding component of the model. Not all the model bleeds, but the components that are important to bleed. And the sensors on the side, you can see we get real-time assessment of the surgeon performing these procedures and how much tension they're putting on the nerve. Finally, the anastomosis, they have to take the inner part of the mucosa and coapt it to the inner part of the mucosa in the urine channel. But the most important thing is to create a watertight anastomosis, you have to release the pressure. And that's something that when you train them in the virtual simulation, that doesn't teach them that they have to coapt that posterior plate. And this is where the majority of leakage happens. So it's simulation within the context of the procedure. We were very interested in developing what we call CROMs, which are clinically relevant objective metrics of simulation. So metrics that are clinically relevant, but also metrics that are objective, not something where a surgeon has to look over it and then give you a score. This is something that comes right out of the simulator. So we started with thinking, how do we assess our procedure in robotic prostatectomy? So this is after the prostate's removed. Positive margins are a big thing in cancer operations. So what we did is we infused the prostate with a fluorescence that doesn't light except after we activate it. And you can see that the surgeon here can see, the trainee can see the positive margins that have resulted from him cutting through the prostate. We found something, and this was actually found through a way where we just turned the Firefly, which is now standard in any robot, and you can actually see the margins. See, it's those big green chunks, not all of it green, but the ones that highlighted. So you activate Firefly at the end after you remove the prostate, and you can see the margins. And that's where the trainee says, oh, I think I got too close there, so let me go back to the video and watch it and figure out what I did wrong. Making sure that the bladder, it doesn't leak after the surgery, that's a big complication. So what we do naturally is fill the bladder with 120 cc's of saline and make sure it doesn't leak. Here, the trainee, when it leaks, can look at which suture exactly. Was it the 5 o'clock? Was it 7 o'clock? Was it the posterior plate? Where did it leak? And they can look at the specimen and realize that this is where the defective stitch was. We correlated that with the race score, which is a subjective means of assessment of the video, and found a very high correlation. I was always under the impression that hydrogel had some sense to it, or you can integrate things in it. And I was true, because we can put these sensors inside the hydrogel and make it one so that we can actually measure the force that we're looking at. So here is where we got these sensors, we calibrated them, created a closed circuit and a special software that can read it, and then placed it inside the model. And here you can see an expert. They are producing some tension on the nerves, which is normal. Nobody does a tension-free nerve sparing procedure, but it's limited in how much deflection there is. There's very controlled movements. But if you look at the trainee, they're all over the place. They're not only dissecting in the wrong plane, causing these spikes in the sensors, but they're also maintaining a very high level of traction. This is the difference between the expert and the novice. We give them a readout at the end, and we correlated that with the GEAR score, which is a known subjective tool for evaluation. Not only did we have a high correlation with the total score, but also found a very high correlation with the force sensitivity aspect of it. We are now using artificial intelligence and machine learning to actually be able to measure the amount of sensing that's happening in the nerve during the procedure, but also be able to give us real-time feedback. And we're using a combination of the video using computer vision and the sensors to find out how much insult is happening. We have a multi-institutional collaboration going all the way to Australia, the United Kingdom, and we also have quite a few major sites in the United States, and we are all collecting data to make that algorithm quite strong. So when we look at patient-specific simulation, it starts out with using a patient's CT scan. So this is the patient's CT scan with the tumor. We then, a series of molds, very similar, but it starts from the basic unit, which is the renal pelvis or the renal hilum. Then we add the medulla, the tumor, the cortex. And if you see in the picture here, you can see the holes of where the bleeding is going to happen when you cut through the tumor. We wanted to make sure, and this is the basis of my R03 grant that I just finished, we compared our tissue consistencies, very different formulations of the hydrogel with live cadavers that allowed us to look at certain consistencies that were required. We did what we call an indentation test, a compression test, and an ultrasound elastography test. We even did tests on the bleeding because this is something that bleeds. So we wanted to make sure that the flow that is running into the kidney was reduced when we pull up with a consistent manner on that base stitch for hemostasis, the first layer of our suturing. We also wanted to make sure that the pledgets we use are actually something that don't rip through the kidney when excessive force is placed to them, because we don't want to be teaching them something that's very wrong. We are now using what we call infrared extensometers to enable us to look at the minor tissue injuries that happen rather than the major tissue injuries. We want to make sure that the anatomy is also correct. So we CT scan the model and then overlay it to the actual CAD that was used to make the model. And then we can find a visual difference where it tells us how far we are off each model. And we were within millimeters of even the tertiary vessels of the renal artery. We take the model alone. The model is valuable, but not as valuable if you put it in the retroperitoneum, cover it with intestines and an abdominal wall, recreating almost half the patient's body, take it down to your operating room, hook it up with blood and urine, and then actually do the simulation. So we use these. We have currently 100 patients in which we've practiced the surgery before. We use this for only complex patients because it involves surgeon time. And we found a very high correlation between what happened in the practice and what is happening in the real surgery. You see those small bands at the base of the tumor I'm dissecting? That's not something we intentionally put in. That is something that's because we've recreated every single layer of the kidney very accurately. At the end, the surgeon actually gets to look at the model, find out how close they got to vital structures, were their sutures intact, is there anything they could do differently in the surgery itself? We did a study where we did a correlation between both of these, but the most important study is this one, where we actually took those 19 patients in which a rehearsal was done prior to that and compared it to a retrospective cohort of patients with the same complex tumors. We found a difference, not in blood loss, because these, again, are experienced surgeons, but in hospital stay and complications, almost a 6-fold difference in complications and a 2-day difference in hospital stay. In the US, that's about $1,800 per day. We also found a difference in positive margins and violation of the pelvic calcial system. Complications like this, like you can see here during rehearsal, could be easily avoided had it been done prior to the procedure. This is our basic training model. And this is something that actually, this video was actually came from the Orsi Academy, and they actually tried our models in their extended curriculum for partial nephrectomy, and they were able to utilize these models in their training also. We are also interested in developing expert surgeons to do new techniques. So the techniques, which is very common in Europe, but less common in the US, is actually using the transplant to put it into the recipient, not the donor, not using the robot for the donor, but using the robot for the recipient. So we developed this model from this CAT scan of the donor and the CAT scan of the recipient put those together, and we actually trained a robotic naive surgeon that only does laparoscopy to do this. And in their first couple of cases, their ischemia time was between around 15 to 19 minutes. And they got to replicate the entire procedure from the anastomosis all the way down to even the reimplantation. This is something, like I said, crisis management training. What we did is we did a needs assessment here at the University of Rochester involving 30 surgeons, first assistants, circulators. They found that there was a need for training for crisis in the OR for robotic surgery. It needed to be a full immersion simulation, but also needed a curriculum that was self-paced, that was online. So we developed, number one, a model that bleeds causes a massive amount of bleeding. And that model would be utilized for the surgeon then to need to emergency undock. So this is, for example, one of our surgeons doing it. So to add to the bleeding that we caused, we found a way, and we worked with Intuitive for this, in order that we can go into the robot itself and cause the instrument to misfire. So the stapler cuts, but does not staple. So now they have to use their fourth arm to control the bleeding. And then because the bleeding is so intense, they have to then go convert, make a small incision, go down with their hand, control the bleeder, and then under vision use the instrument release kit, which we realized quite a few people don't know how to use, to remove the instrument. So she made the incision, got her hand in, and then used the instrument release kit to release it. And this is after we did a curriculum with them that was online to teach them how to do this. We have also moved into making single port trainers, and I'll go through this very quickly. What we've done is we've replicated the entire partial nephrectomy, but going through the back, retroperitoneal approach. So we needed to recreate the whole abdominal wall. And what we did is we were able, this is actually prototype 1.0. We've tried it in several other instances. Even Dr. Kauk tried it, was very impressed with what happened with it. And the same way that we go in, which is through the stab, we then put a balloon inside to enable us to do a balloon dilatation, separating the kidney from the retroperitoneal muscles, and creating that realistic feel of access to the retroperitoneal space, because that's something not many urologists know how to do that weren't trained in this technique. And then after that, they actually go in and do a partial nephrectomy using a single port robot. And this was challenging. This was not easy to do because, again, the instruments are not as heavy. They don't have the same amount of motion and flexibility in it. So we were able to create this trainer for people to be able to use for single port surgery. We've created also an anastomosis to teach surgeons how to do the vesicourethral anastomosis, which is part of the prostatectomy. And this is the most challenging part of it also. And that's kind of an overview of where we've gone from very simple trainers to advanced trainers that allow us to explore new robots, new techniques, but also for train for crisis events that we hope never happen. And if they do happen, we want our team to be prepared.
Thank you so much, Professor Ghazi. It's I think impressive lecture. I think, we have seen things that most of us, I think, couldn't dream about. So thank you so much. I think very, very impressive.
Thank you.
If you're available, I think it would be good to have some discussion, some questions. So if your OR time permits, please stay with us for, the lecture from Professor Gallagher, and then we will just all together go through the questions and comments. Okay. Definitely,
we'll stick around for Professor Gallagher's lecture, and then I'll turn my camera off, and I'll be there, but with audio only.
Thanks so much. And now it's my big pleasure to introduce you to Professor Gallagher. He's I think the one that really developed proficiency based progression metrics, and I think someone that we have had the honor and pleasure to work with for the last few years in the development of those metrics for robotic LAR. He's someone I do appreciate a lot, a good friend, I would say, and it is our pleasure and honor to have him with us today. So please, Professor Gallagher, go ahead with the lecture. The floor is yours.
My name is Tony Gallagher. I work at RC Academy. I'm Director of Research and Learning. These are my disclosures. So I work at RC Academy. And as I was saying, the problems I want to talk about, I'm talking specifically about robotic surgery, but really the issues apply across procedure-based medicine. And there's abundant evidence of unsafe clinical practices, no matter which area of procedure-based medicine you look at. And part of the problem is we're still using a training paradigm that was developed during the late 19th, early 20th century by Halstead at Johns Hopkins. And the problem is that at the start of the 21st century, that training paradigm has morphed into something that's maybe not as robust as Halstead had originally intended. And we're told that the solution to the problem of training the appropriate skills is competency-based training. And the reason I developed a proficiency-based progression was actually to deal with the problem of competency-based training. At RC Academy, we have excellent training facilities. We know that, but we're also acutely aware that excellent training facilities does not necessarily equate to effective training. Effective training is about understanding the learning process. We've known this is a standard learning curve. We've known what the learning curve looks like for more than a century. We take a novice, we give them some education, they're deemed an advanced beginner. We give them some training and they're deemed competent. And what you can see is competence really not that far up the learning curve, whereas proficiency is considerably further up the learning curve and well on the way to be an expert. And the problem is we really don't or can't or won't consistently define what competency is. And in the late 1990s, early 2000s, when I discovered what competency actually was, when we say competency, we mean minimum competency, I thought about a different approach to training, which was proficiency-based. Proficiency-based progression training is derived from a procedure characterization, and that's partly where Marcus and I encountered each other, and I'll talk more about the data from that in a few minutes. So it's derived from a procedure characterization and implemented with performance metrics. A procedure characterization is the detailed portrayal and description of optimal performance. It's as simple as that. And the metrics derived from that procedure characterization certainly will include the steps of the procedure, but it should be it can be a procedure, it can be a task, it can be a communication skill. But what we pick is a reference approach to the performance of that procedure. We can't characterize, or it's too much effort to characterize every approach. So we pick a reference approach that's common, that's what we hope the trainee experiences earlier in their learning curve. And we identify how it should be performed, in what order, with what devices. But it turns out what's most important is what should not be done. And that is the errors and deviations from optimal performance. What are metrics? Well, metrics are numbers that give us important information about performances. They help transform vague performance characterizations to something more tangible and quantifiable. And metrics give us robust and reliable performance measurements and provide a base from which to make comparisons, to set benchmarks, to suggest improvements. And metrics should not just consist of what is easy to measure. And unfortunately, that's what most organizations do. They measure the number of the amount of time somebody's done training, the number of procedures done, the number of training trials, and so on. So who do you want to develop the metrics? Well, you want 3 to 5 procedure experts. 3 is probably sufficient. And experts is probably the wrong word. I would say experienced surgeons or practitioners. And they have to be genuinely good at performing the procedure. They can't talk a good game. They need, possibly one of them needs to be a good teacher. And the reason is that they've got the taxonomy to describe the performance characteristics that we want to capture. The individual should have no major ego or psychopathology issues. I'm not joking about that. You do not want somebody who has to talk first, who has to talk last. It always has to be their way. They have to have the last say. Those individuals don't belong in that group. And I mean, mature experience has taught me they're probably not that skilled in the first place. So they need good social skills. They need the ability to discuss, to debate, and to compromise. Because when you have 3 skilled individuals talking about a procedure that they're very experienced and very good at, they're going to have different approaches or nuances to the way that they do it? Well, we're going to have to come up with a consensus and a standard approach to doing it. They need good command of the English language because we define the metrics rather than describe them. So when we define a metric, there's a yes, the trainee did it, no, they didn't do it. It's as simple as that. They need a sense of humor, they need to be pragmatic, and they need commitment. They're not going to do this in a few hours. This takes days. The process is always the same. We take a new skill, a new device, a new procedure, it really doesn't matter. We characterize it in detail with the 3 individuals that are experienced practitioners, and then we explicitly define what it is we want to measure, and then we validate. Do the metrics distinguish between experienced and non-experienced practitioners? Do your peers concur that the metrics are a good characterization of what it is that you want to capture? And then once we're satisfied with the validation, we quantitatively define a proficiency standard based on the mean performance of experienced practitioners. That sounds straightforward, but as you'll see in a couple of minutes, that's not that straightforward. And then the trainee is required to engage in deliberate practice simulation training. Deliberate practice is different from repeated practice. Repeated practice is what we normally do in the simulation laboratory, where they repeat something over and over again and hopefully they get it. Deliberate practice is different. Here we use the metrics to give the trainee explicit formative feedback on what they did right and what they did wrong. And what they did wrong, we actually show them how to fix it. And what we found is this accelerates the learning curve enormously. So the trainee continues with their deliberate practice simulation training, and only when they demonstrate the proficiency benchmark do they proceed to clinical practice. The development and validation of the metrics, it takes 6 to 12 months. One of the biggest hurdles in this process is getting the surgeons together to characterize the procedure. Now, during the pandemic, we've learned that we can do it online, but you still need face-to-face meetings. And everything else, anything to do with training actually is built on the validated metrics. They're a prerequisite for the effective training. And as I alluded to, okay, the validation of the metrics for something like construct validity, where we want to demonstrate the metric the scientific properties of the metrics, should be straightforward. Well, here's an example where it's not so straightforward. Alex Motry, who's the CEO and medical director of RCA, Peter Wicklund, who's the chair of urology at Karolinska, Marcus Griffin from Martini Clinic, and myself, we characterized the metrics for robot-assisted prostatectomy a number of years ago. We identified 12 phases, 80 steps, 245 potential errors, 57 general errors, and 110 critical errors. We took them to a modified Delphi meeting to see if we could get consensus amongst an international panel of very experienced urology surgeons who perform RARP. And we got consensus, very good consensus. And then we moved to establish the construct validity of the metrics. That is, do the metrics distinguish between the objectively assessed performance of experts and novices? And for this procedure, we used 12 very senior, very experienced international experts. These are the individuals that you actually see on the podium. An expert was defined as someone with more than 500 RARP cases. In fact, most of the surgeons that we included had completed at least 1,000. And the novices were surgeons, urologists, who'd finished their residency and had completed a 6-month fellowship on RARP. So they had to have done more than one independent RARP case, but less than 10. And for the purposes of this assessment, we were only interested in nerve-sparing procedures without lymph node dissection. So here, all of the videos were assessed by 2 trained surgeons. The inter-rater reliability, as you can see, the mean inter-rater reliability was 0.85. 0.8 is the quality threshold. None of them dropped below the 0.8 threshold. Here we have the mean and 95% confidence interval. We can see that the metrics are discriminating between the two groups, but not statistically significantly. The experienced surgeons are making 9% more steps. I'm not really bothered about that because steps is not a good discriminator anyway. Errors is a different kettle of fish. Here we can see that the experienced surgeons are making 82% fewer objectively assessed intraoperative errors. That looks okay, and it doesn't look okay. Look at the performance variability, the 95% confidence interval of the attendings group. So what we did was we looked at the individual performance of the trainees and the consultants. There was nothing going on for steps. Errors was a different kettle of fish. The novices, we're seeing a distribution of scores, that's fine. They're still bunching around the mean. The experienced surgeons, it's not so good. What we're seeing is 3 surgeons that are performing outside the 95% confidence intervals, and 2 of them that are performing worse than the worst trainee. Now, these are not junior consultants. These are very, very experienced international leaders in the field. So we split the scores at the median of total error score, and we re-graphed the data. And what you can see, this is the mean and 95% interval of the novices who were performing best, the novices who were performing worst. The consultants who were performing best are genuine experts, and the consultants who are maybe not so expert. And what you can see is that the novices who are genuinely novice were making 4 times fewer, 4 times more, 4 times greater number of objectively assessed intraoperative errors than the experts who were performing best. And here's our problem. Here we have a group of consultants and attendings, a very experienced urologists with high number of procedures, and they're making 16% more intraoperative errors than the novices who are performing best. And look at the performance variability. So when we had collected the data initially and before we'd done the assessment, I asked Alex and Peter and Marcus, I said, okay, which phase of the procedure do you expect to see the biggest difference? That's important. You know, when you see the greatest difference between the experts and the novices, it's important because we'll train all of the procedure, but there are certain phases of the procedure that discriminate best between the two groups we're going to concentrate on. Here, what you can see is the experts who perform best, they're making low to no errors across the 12 phases of the procedure. Here we have the novices who perform best. Alex and Peter and Marcus agreed that the phases of the procedure that would best discriminate between the experts and the novices was the left and right lateral dissection of the neurovascular bundle. And that's precisely where we see the difference. The sort of error that we're looking at is damage to the neurovascular bundle by cutting, clipping, or use of diathermy. The neurovascular bundle is bluntly dissected off the prostate due to excess tension. So here we can see that the novices who are performing best clearly did worse during those 2 phases. Not surprisingly, the novices who perform worse they're performing worse again. And here we have the consultants and attendings who are very experienced, but are also doing quite poorly during those phases. And the difference is it's quite significant. Now, the issue that you want to consider is, would you want the consultant or attending group, you know, that we have represented here, would you want them doing a prostatectomy, a robotic prostatectomy on somebody that you love? I know what my answer is. And the degree and quality of neurovascular bundle sparing has been shown unambiguously to be important for postoperative sexual function. Well, maybe the data is atypical. Maybe it's just an aberration. As Marcus alluded to himself, Mr. Samsung 2 and Professor Klaus Matzel and myself, we developed the metrics for the low anterior resection. The results should be out in one of the British Journal of Surgery, open later this year. So we identified 14 phases of the procedure, everything from the patient positioning all the way through to transfer the patient from the operating table to the bed. There were 129 steps, 87 to 88 errors, depending on the gender of the patient, and 115 to 116 critical errors. So we took them to Delphi. We presented the metrics after discussion and review. The metrics, we asked the Delphi panel, okay, the metrics that we're presenting to you may not be the way that you would do the procedure, but they're not wrong. That's different from asking them their opinion. And with that question and editing and adopting the feedback from the panel, we got 100% consensus. Then we moved on to construct validity. The novice surgeons in this study, those that had considered or had done less than 30 robot-assisted low anterior resections were considered novice. Those that had done more than 30 were considered experienced. And here we have the mean and 95% confidence intervals of the steps completed by the three groups. We had split them at the median score of the total error for the consultants. And what you can see is that the consultants who were performing best were making 43% fewer or completing 43% more steps than the novices. It's not significant, but again, that's not a surprise. More surprising is the errors didn't really discriminate between the consultants who were performing best and the novices. The critical errors did. The consultants who performed best were making 45% fewer critical errors, and there were in total errors did discriminate. So they were making the consultants who were performing best were making 58% fewer errors than the novices. But there was something else more worrying in that data. The consultants who performed less well, who were making more total errors across the study, they were performing slightly worse than the novices for critical errors and for total errors. And they were performing considerably worse than their consultant colleagues. Again, I asked Marcus, Sam, and Klaus which phase would discriminate best. And what they suggested was the phase 9, the rectal dissection, which began with visualizing the working end of all three instruments in the pelvis and ended when the divided rectum was placed in the abdominal cavity and in view. The reason we define the beginning and end of a phase, because if we want to specifically train a phase, we know where it starts and we know where it ends. Here we have the steps, the errors, and the critical errors. Again, steps really don't discriminate. What you can see is the errors actually do discriminate in this analysis. The consultants who performed best were making 46% fewer objectively assessed intraoperative errors than the novices, 59% fewer critical errors, and overall they're making 51% fewer total errors. But again, what we're seeing is performance of the consultants who didn't perform so well. They're showing huge variability, and they're performing more like the novices than they are their consultant colleagues. So the robot-assisted low anterior resection performance metrics were agreed by an international modified Delphi panel. The metrics reliably discriminated between the operative performance of experienced and less experienced robotic-assisted colorectal surgeons. Some experienced colorectal surgeons performed poorly when their operative performance was assessed with the metrics. And to be frank with you, okay, we say I've demonstrated the data in urology, and in colorectal. We're seeing the exact same in anesthesia when we're looking at central line placement, in orthopedic surgeons when we're looking at trochanteric hip fracture, for CRT placement in interventional cardiologists. What that tells me is that the metrics are granular enough to identify individuals that are not so good at performing the procedure. So why are valid and reliable metrics important anyway? Well, for efficient and effective training, to be quite frank with you. The best example comes from the Arthroscopic Association of North America. A few years ago, they were building a new learning center in Chicago. They were spent a lot of money on it with the Academy of Orthopedic Surgery. They have the most fabulous training space. It's probably one of the best surgical skills labs that I've ever been in. And they came to me and they said, okay, we do good training. We're pretty confident we do good training, but we want to make sure that our training is the best that we can offer our trainees. So what we're wanting to do is to identify, is there a better way to train surgical skills? So to assess that hypothesis, we developed the metrics for an arthroscopic Bankart procedure. I mean, obviously there's unanimous agreement amongst the arthroscopic surgeons. Their arthroscopic approach is superior. A Bankart is where you have a labral tear. You've got to insert 3 anchors on the bone, and then arthroscopically you've got to suture the tear closed. So we developed and validated the metrics for the Bankart procedure, and then we defined proficiency benchmarks for training. We then proceeded to do 21-site trial across the United States, everywhere from Amherst outside Chicago to Tufts in Boston to Yale University in Connecticut. For training, we used the arthroscopic suturing and knot tying board that has existed for 20 or 30 odd years. We also used a silicon shoulder model made by Sawbones. The trainees had the opportunity to practice their skills on a cadaver shoulder, and they completed their index assessment on a cadaver shoulder. Now, we wrestled with this question for quite some time, and we had wanted to do it on patients, but there was an argument within the group that if we completed the procedure on patients, the index assessment, that trainees who were performing poorly, the attending would stop them. And so therefore we would have an underestimation of their true performance level, that they're probably worse than the assessment showed. So eventually we agreed we would do the index assessment on the cadaver. However, the important lesson I want you to take away from this slide is we use what was available today. The Arthroscopic Association of North America is not poor, and they have spent tens of millions on virtual reality simulations, and they've really got very little for their money. We went to the storeroom in the Training Orthopedic Learning Center, and we looked at what was available, and we used what was on the shelves. Then proceeded with the randomized trial. We had 3 groups. Group A were the traditional ANA trained group. Group B and C were simulation trained. Then it was, at that time, it was ANA policy that everyone had to view an online orientation before they got to Chicago, to the training center. We assessed the aptitude of all of the trainees. The trainees were orthopedic residents in ACGME approved residency programs. They were in years 4 and 5. All of them had their aptitude assessment. There was no difference in their aptitude. And then they proceeded with their normal course. For the ANA course, they got lectures from experts. They had knot tying practice, had the opportunity to practice their skills on a cadaver. Group B had the same, plus they had the opportunity to practice on a simulator. And Group C had the exact same as Group B with one difference. They had to test the proficiency throughout the entire training program. The proficiency benchmark was always based on the mean performance of the faculty who took the exact same assessment as the trainees. So they took the online assessment on the didactic, they tied the knots, and they performed the task on the simulator. And at the end of the course, all of the trainees were required to perform an assisted but unaided Bankart repair on a fresh cadaver that was video recorded, and it was assessed by 5 pairs of attending arthroscopic surgeons from across the United States. The inter-rater reliability of the assessment was 0.93. So the trainees came into the Orthopedic Learning Center in Chicago on a Friday afternoon, and they left on a Sunday afternoon. So the course was over a weekend. Here we have the mean and 95% confidence intervals of the procedure steps completed. What you can see is that the proficiency-based progression training group are completing significantly more procedure steps, but only 10% more. And what we realized was, okay, procedure steps are important, obviously, for the completion of the procedure, but they're the least sensitive quality measure. You can complete all of the steps and tick the box, but you can do it badly. That's not going to be picked up on that metric. However, errors will. Here we have the mean and 95% confidence interval for the objectively assessed intraoperative errors. And what you can see is the proficiency-based progression training group are making 56% fewer objectively assessed intraoperative errors than the standard ANA training group. And they're making 41% fewer than the group that had the exact same training with the same level of faculty, the same educational resources. We then asked how many of them demonstrated the proficiency benchmark. That is the mean of the experienced faculty. They had to complete a full 3 anchor repair with no more than 3 errors and no more than 1 sentinel error. A sentinel error, you and I would call a critical error. The arthroscopic surgeons had difficulty with that. Their argument was, okay, if somebody in colorectal surgery makes a critical error, it could compromise the patient's safety or life. They make a critical error or a sentinel error in the shoulder or something serious. The patient may never move their arm correctly again, but it's not going to kill them. What we found was that for the traditional trained group, less than a third demonstrated the proficiency benchmark. More surprisingly, what we also found is that for the simulation trained group, they did only marginally better, just over a third demonstrated the proficiency benchmark. For the proficiency-based progression trained group, it was 3/4 demonstrated the benchmark. And when you analyze that in a logistics regression, you can see that the proficiency-based progression trained group were more than 7 times as likely to demonstrate the benchmark. So the conclusion from the Anna Copernicus study was that proficiency-based progression simulation training produced an unambiguously superior surgical skill set, but it has to be more than an interesting educational experience. I mean, Anna thought they did good training. Okay, they've accepted the data, but they were quite shocked by the data, particularly the group where we added simulation and there was minimal impact of the simulation. It's really what the data suggest, it's the metrics applied to the simulation that actually makes the training effective. During the first part of lockdown, we completed a systematic review and meta-analysis of all prospective randomized and blinded studies that used a proficiency-based progression approach to training. And what we found was the proficiency-based progression approach to training was associated with a 60% reduction in objectively assessed performance errors. One of the other things we discovered is there's lots of studies out there saying they're doing proficiency-based training or mastery training or competency training. Now, we're really not quite sure what they do, but they're absolutely not doing proficiency-based progression training. We're currently doing, at ORSI, we're currently doing a systematic review of what those studies are doing, and we'll probably publish the results either later this year or next year. So why has training of surgical skills acquired a new significance? I give my inaugural professorial lecture at the Royal College of Surgeons in 2006, and somebody in the presidential line stood up and said to me, okay, Tony, we get that you can improve the skills of the surgeon. That really doesn't make any difference. He said he was in a practice of colorectal surgeons. He said, He does the procedure one way, his partners do it different ways, but there was really no difference in their outcomes. That really didn't ring true to me, but there was no data to contradict them. There is data now. The first study to address the issue of skills related to clinical outcomes was by John Birkmeyer, published in the New England Journal of Medicine in 2013. And what he did was he looked at the outcomes of laparoscopic bariatric surgery and as how it related to the skill of the surgeon and the patient outcomes. He had attending, not resident, attending and experienced bariatric surgeons send in a video of their best, or a video recording of their best laparoscopic gastric bypass. That was assessed by their peers. Their skills were objectively assessed, blinded as to who they were actually assessing. And on the basis of that assessment, the surgeons were banded into 4 quartiles. Those that were performing worst, 2 middle quartiles, and those that were performing best. Then all of the patients those surgeons operated on over the next 6 years were followed up, and they collected data on the complication rates, readmission rate, reoperation rate, and mortality rate. And to be honest with you, not surprisingly, the surgeons who were assessed as having the best skills had the best outcomes. That really wasn't a surprise from that study. This was the surprise. What they demonstrated was that the smallest difference between the 2 groups was reoperation rate. The surgeons who were performed best, who had demonstrated the best technical skills, had a 52% lower reoperation rate. The surgeons who demonstrated at the outset of the study to have the weakest surgical skills had an 81% higher mortality. That study had a significant splash at the time, but now, I mean, I hear a lot of surgeons saying, well, it's only a bariatric procedure. Well, there's data from your own domain in colorectal surgery that was published in JAMA Surgery in 2020. And they did something similar to Birkmeyer. And what they did was they looked at the outcomes of the surgeons performing a TME. They assessed the performance of the surgeons, banded them into those in the lower quartile performing worst, the middle quartile, and those performing best. And what you can see, the surgeons who were performing best, it took significantly less time to do the procedure. They did much shorter. They had lower blood loss. Is that a big deal? Well, that's for you to say. What is a big deal is 30-day morbidity. And what you can see is the surgeons who were performing best had a 53% lower 30-day morbidity, and they had an 88% lower surgical morbidity. Evidence is accumulating that demonstrates performance and skills do impact on clinical outcomes. And I think that evidence is going to accelerate. So what's missing? Well, what's missing is that I think that surgery must learn, it's not just surgery, it's cardiology, it's across procedure-based medicine, must learn that a training course or simulator may look to have all the right bits, but it's simply, it's not right. The ANA data clearly demonstrates that. When metric-based training simulations do not exist, improvise. Training effectiveness is about the metrics and the curriculum. The simulator is a potentially very powerful tool for deliberate practice training with metric-based feedback. And we know deliberate practice training with metric-based feedback accelerates learning enormously. Metric-based feedback to trainees should be unambiguous. The development of validated performance metrics should probably be the #1 priority for the different surgical disciplines. Surgery must develop a better understanding of simulation. Elaborate, complex, pretty, or expensive simulation platforms do not necessarily mean better. Education and training should afford trainees the opportunity to learn what to do in a safe environment. but it also should, maybe even more importantly, afford them the opportunity to learn what not to do, because trainees learn more from errors, and errors is what we want to impact on most. And simulation training, it's not as simple as you buy the box, the virtual reality simulator or whatever, and then you point the trainee at your learning technology and you tell them to learn. It's not as simple as that. I think there's an urgent need to robustly establish if proficiency-based progression training improves patient outcomes, that is morbidity and mortality. And if it does, by how much? I'm pretty sure I know the answer to that there. But what's needed is a multi-center, prospective, randomized and blinded study. To conclude, proficiency-based progression simulation training works. The principles and practices are the same across all of medicine and healthcare. But training must be more than an interesting educational experience. I mean, I work with a lot of disciplines, and one of the things that they do is they assess how much the trainee enjoyed the course at the end of it. I mean, yes, I want them to enjoy the course, but to be quite frank with you, I want to know, more importantly, at the end of training, what can they do? We really have to know with some certainty what the trainee knows and what they can do to a quantitatively defined performance level. I mean, and at RC Academy, we're aggressively pursuing a proficiency-based progression approach to robotics surgical skills training. Thank you.
Thank you so much, Tony. I think it was, again, an impressive presentation, lecture, and really thank you for being with us again this evening. Would like now to introduce Dr. Roberto Ballestero. He is a neurologist in Valdecilla, a good friend of mine, and he's also moderating the session with me today. And I think we will start if Professor Ghazi is around still. We will probably start with the questions for him. He I think has to go. Good.
Well, congratulations, Dr. Ghazi. For me as a urologist, it's a pleasure to have you here because, well, I have to recognize that you are one of the urologists who has most impressed me in the last years.
Thank you so much.
I have to recognize that I'm a fan of your work. And when I started working with the engineers at my center, I showed your videos, and the first thing I told them was that we had to get closer to your work. So your work is fantastic.
Thank you so much.
You have told about the use of your model as training for residents or novice. But well, imperialistic organs has several applications. For example, information for the patient, surgeon-specific training or practice several cases. In your opinion, which is the most useful?
Well, that's a great question. Thank you very much for all your kind words. I would say this model is fairly resource intensive, meaning it takes a significant amount of effort to build one of these. And therefore, I would say that it has to be somebody that has achieved some level of competence in the basic use of the instrument. So for example, if we're talking about robotic surgery, they have to know how to utilize the actual robot and how to manipulate through very small tasks. Then moving over to the advanced skill set is the procedural model. We've created something in the middle, which are task trainers. So only the vesicourethral anastomosis, only the nerve sparing component, only the bladder and neck, so that the trainees can kind of get through that difficult task with mentorship, allowing them to go through it slower, because the entire procedure in a novice takes about 3-4 hours. So it's a lot for a proctor to be training that time. So we have them go through proficiency in virtual reality. Then we go through proficiency in small task trainers, which are partial task trainers. Then they proceed over to the procedure itself. So it's for somebody that wants to learn the procedure, but has some competency in how to use the technology. But at the same time, we've also used this technology significantly for expert surgeons who want to try new approaches. So, my first single port procedure happened only after I tried it on one of my models. then started advancing to patient care.
Mm-hmm. And what do you think about the use for practice the procedure before the surgery in complex cases?
Yes, in patient-specific simulation, I agree, is something that I didn't think was very valuable until I started doing my own cases. You cannot imagine the amount of benefit that you feel in confidence in your ability to identify the anatomy, in expecting what. So there's no unexpected events anymore. You know exactly where it's going to bleed. You know how much invasion of the pelvic caloceal is going to happen. There are no surprises. The procedure becomes very easy, and you can feel more confident in doing some of these very complex procedures. So I would say for complex procedures, it has shown value. For very simple procedures, then it becomes something that is less likely to give you the benefit that you need based on the amount of effort it takes to make them.
Mm-hmm. What can you say us about the cost of these models?
So cost is a big issue. So we are a nonprofit a research lab, and therefore, as a result, we cannot really say the cost of the models. What I can say is they're cheaper than a cadaver. They are more useful than a cadaver, but they are one-time use. That's why they are such high fidelity. If you can make these in your own institution, they are very cheap. But the people who make this in my lab have masters in biomedical engineering. So that's quite a significant amount of hourly pay. The materials cost very little, but it's the know-how. It's how you put everything together. You layer each layer on its own. That's why it's so high fidelity. And as a result, it does take quite a bit of time. So the number of hours it takes to make approximately a partial nephrectomy model is about 20, but then we don't make one. We make them in 3, 4 at a time. So then your output is approximately 3, 4 models at a time.
Okay, thank you very much. Marcos, perhaps?
Yeah, well, Professor Ghazi, while developing these models, while using these models, and I'm pretty sure you're aware about the work that Professor Gallagher is doing, is it there something you have done already together, or during the development of these models, or while using these models, have you implemented proficiency-based progression metrics in them? I think that would be a great combination in my mind. Well, can you tell us about this?
And like Professor Gallagher said in his lecture, he is the expert on proficiency-based training. The metrics that we've placed in the models are mainly related to errors, right? For the detection of errors. And what we're hoping to do is we're hoping to do this in real time. So as they're doing the error, you can actually identify it, right? So now it's a summative assessment, meaning at the end of the simulation, they know what their errors are, and then they have to, but our errors are not granular enough. So we're not at that level of granularity. That's where we're using AI to help us identify those granularity. Now it's a positive margin plus or negative. It is leak or no leak. And those are errors that when they identify, they can go and change their approach. So the result is no negative, negative margins, no leak, minimal tension on the nerve sparing. So what we're trying to do is not only instill sensors in the nerve, but also in the bladder, so that at that point, there's also a good amount of data that comes during the suturing also. So, but for that wealth of data, we need AI. We need artificial intelligence to do that.
Yeah, just the feeling I have is that if we would be able to build a procedure model, like the physical model, like the ones you presented or you are building already, and we would be able to build them with the knowledge we have on proficiency-based progression metrics for, let's say, robotic radical prostatectomy. The model built in order to train and assess the steps developed, let's say, by Professor Motri, Gallagher, and the rest of the group. I think that would be a great combination. At the end of the day,
I think that's incredible.
And that's something that would add on top of what you are already assessing, which I agree. I think they're also quite valuable areas, of course, margins and leaks, and that's something that you can objectively measure if there was a leak or if there was a. But at the same time, there are probably some steps that might be missing or not, and that there might be some other errors or critical errors that might be not you might not be able to assess at this stage, and maybe using those metrics you might be able to well, and that's something that I agree. It might be easier if you're able to train artificial intelligence, but it's also something that could be done with just surgeon time. I don't know.
Yep.
What do you think?
No,
about
I totally agree, because I think artificial intelligence needs what they call ground truth, which is basically what Dr. Gallagher is doing. So I am totally a proponent of teaming up to do this. The beauty of our model is it's a standard. It is the same model. So it's very easy to be able to say that you have a standard model for training, where in cadavers it becomes very difficult to do that. And virtual reality has achieved that, but in cadavers it's very difficult to say that these are standard models.
Yeah, completely agree. And thank you so much. And I think just a couple of few questions. I know you are in the OR already. So do you think that it is feasible to expand this to other specialties? I mean, how easy it would be to build, let's say, colorectal models or GYN or other specialties?
Yeah, we have versions of those. And the idea is there needs to be a demand, right? There needs to be somebody in which we are collaborating with that needs a significant number of these models for us to be able to put in the effort that it makes to make these, right? Now the demand is very high in urology in the US and in other institutions. So I would say we're focusing on that. But if there is a need, and I know Orsi Academy is a great academy for training, if there's a need and there's a significant amount of models that need to be made, then it makes sense for us to put resources into that area. Because if we're gonna just make one model, then it makes no sense to do that.
Great. Okay, thank you so much. And Tony, what do you think about this?
I mean, using the total model, I'm not too sure that I'm a big fan of. But you see, we have some data that I didn't talk about here. Okay, we know from the construct validity data that the most errors are during the neurovascular bundle dissection. We have data from Martini Clinic on real patient outcomes. And we know also from the experienced consultants at Martini Clinic that the patients with the bad outcomes have the greatest number of errors around the neurovascular bundle dissection. If I was to propose something, what I would say is, okay, we train the trainees to do the procedure on whatever low cost simulations we have. And then for the neurovascular bundle dissection, that we actually use Professor Ghazi's simulation. There we're going specifically to the crucial part of the surgical procedure that we want to train the greatest fidelity. That's where I would see the greatest use for that type of simulation. And I mean, I would put a lot of money on that would be successful. Because that's why we do. That's why I asked you guys the same question as I asked Alex and those guys. Okay, which phases of the procedure are best discriminated? You train all of the procedure, but you concentrate your training efforts on the phases that best discriminate between the experts and the novices, because that's where the novices need the greatest attention to education and training. The low fidelity or inexpensive simulations we use won't achieve the same fidelity of training as what Professor Ghazi is demonstrating. But at the end of the day, it still has to be affordable. I mean, because training space is very expensive. I mean, one day, just with the facilities that we have, it's like 1,000 to 1,500 euros a day per trainee. That's very expensive, so that anything that we use really has to earn its keep. And if we were to add something extra, such as these high fidelity simulations, which to be quite frank with, I would be a proponent of using that. They've got to demonstrate that they actually add something significant in terms of learning to the trainee. But from what I've seen and what Ahmed has described, I suspect that they would. That's my suspicion, and I tend to have a good eye for what'll work and what won't work.
Well, thank you very much for those comments, and I agree. That's why we made partial task trainers. It becomes very difficult for a trainee to spend 2-3 hours to do the entire prostatectomy. But nerve sparing and the vesicourethral anastomosis have been identified as one of the most critical steps in the procedure, because they lead to functional outcomes that result in patient satisfaction and dissatisfaction with this procedure. So we've developed this. We've isolated the model into different tasks to make it, number one, more affordable, and number two, more likely that we would be able to fit it within a good amount of time.
Yes, but it would need to be paired with the detailed formative feedback. For example, you're not allowed to be applying tension to the neurovascular bundle. If you're using diathermy, you're using pinpoint diathermy, rather than significant bursts. And the trainee needs that formative feedback in real time with the model, because we know that that's what accelerates their learning. It's that explicitness of feedback, and the explicitness is derived from operators as good as Alex and Peter Vicklin and Marcus Griffin, who actually, they have excellent outcomes. And when they're looking at a surgeon doing a prostatectomy, they're going, okay, I wouldn't like to be that patient after surgery, So, but that's what the metrics allow, the metrics and the simulation allow. It allows that wisdom to be passed on to the trainee in a practical way, so that knowing how to do something is not the same as being able to do it. And that's the value of simulation, but it has to be explicit feedback.
No, I totally agree.
That probably also goes together with the difference in between training and assessing the steps and the errors. I think probably knowing how to do the procedure, which is the steps training, and doing it at a, let's say, quality level, which is probably where the errors and the critical errors can employ. And probably that's why while doing or making the different studies you have found differences mainly in the errors, or as we did in the total errors or critical errors, and not in the steps, because probably and that also brings me to the other question, which is and probably you also already comment on that, but does it really make sense to build physical models or training models just only for one of the phases we are developing, which is the one that really, just to make it cost efficient, I would say, the phase that we think it's critical, and you comment on that. I think for us, phase 9, which is rectal dissection, rectal transection, probably that will be a great physical model, and might be good enough and might be cost efficient, because I think one of the limitations we have here is that we have those great physical models in Rochester in the US. We have this great training center in Orsay in Belgium, but nowadays we all have the feeling that robotic surgery is expanding. It's really becoming the new gold standard, and we experienced something similar with laparoscopic surgery 10 years ago, 15 years ago, and I think most of us are aware of the complications and the impact that this had for patients back then. And of course, none of us want to see that happening again. Would making this cost efficient or implementing these models be a good tool to avoid that impact of the new surgeons doing more and more robotic surgery? I
think it goes back to the curriculum again, Marcus. I mean, let me step back about it. Actually, my choice would be physics-based virtual reality simulation as first choice, but the physics-based virtual reality simulations for surgery are absolutely not there. The only area that they're really there for are for the endovascular procedures, the mechanical thrombectomies, and so on. And that's because the market is driving it. Surgery actually needs the same. And until a surgery is there, I think you've got to use what you've got available. And I think it has to be cost effective. I mean, you can't just use simulations for an educational experience. I mean, we use something as simple as chicken models, €5 chicken to teach the urethral and bladder anastomosis. That's fine. And I mean, like €5 a pop, I mean, that's not a big deal, but we have nothing to teach the dissection of the neurovascular bundle. And I think that the simulation has to be fit for purpose. I tried to point that out in my conclusion. Surgery must get smarter about the simulations that they use. the best simulations are the simulations that somebody will use, the simulations that will afford transfer of training, the simulations that you can actually apply the metrics so that the trainee learns something. Like about 5-10 years ago, if you'd have showed me a flow model for a cardiac device for replacing a stent or something, I would say you're wasting your time, until I was actually in the cath lab or in a training lab, and somebody from the company was demonstrating. It was for a mechanical thrombectomy, and it was the deployment of the stent triever. And it was in a flow model, simply warm water running through it. And what it demonstrated is the way the device behaved in the vessel in the brain that the simulation just simply didn't teach. And that one learning example convinced me, okay, I would have a flow model in every simulation course that I was running on mechanical thrombectomy for acute stroke, simply so that the trainee knows and has observed the way the device behaves. And I think good, experienced educator clinicians, they have a good eye for what those are. That's what I think.
Yeah, completely agree. Yeah, the probably also what you found during the end study and while assessing the simulators not being, let's say, as good as the PVP model is because those simulators were not based on proficiency-based progression metrics. I think probably those simulators were developed using other kind of let's say tools, not really the metrics, and that probably makes them not be able to fight in the same conditions as the PV metrics. I don't know if you would be would agree on that.
I mean, they start from, I mean, all of them practically start from the wrong position, and the device manufacturers start from the wrong position. When you have a device, the first person you should go to is the clinicians that are actually good at the procedure, and you should identify, okay, what is it you need to do to deliver this or use this device safely? And how do you know that you're using it suboptimally? And once you have those metrics, you should then go to the simulation company and say, okay, this is what I want simulated, and these are what I want to be able to measure. What is it you can measure and what is it you can't? And I want an honest answer. Instead, what happens is the simulation companies come to the surgeons or the cardiologists and say, I have this fabulous simulator and it simulates this procedure from start to finish, and it has all these bells and whistles. By the way, what is it you want to do? And they're not that particularly interested in finding out at that point what you want to measure. The device manufacturers and the clinicians have to tell the simulation companies, this is what we want to measure. We were developing the metrics for mechanical thrombectomy with Mentis, and we started off with 3 very good interventional neuroradiologists. And we didn't start a course until we had the metrics built into the simulator. The clinicians were the starting point, not the device. And I think the device manufacturers, they're not there yet. I mean, and they unfortunately drive a lot of the simulation market. The clinician's the starting point.
Great. And there's, I think, a lot of work to do. Professor Ghazi has to leave us. He's, as you all see in the already, and his case is starting. So again, thank you so much, Professor Ghazi, for sharing with us your work. Your presentation was excellent, and for being with us these minutes for the discussion. So
excellent. Thank you. This was a great discussion. I would, sit on this panel for another hour. Very great points. I agree with everything Professor Gallagher says, and I would love to collaborate. Maybe we should continue this conversation at another time and see where we can go with this. The combination of both resources, I think,
absolutely
would create an incredible learning platform. Thank you, everyone. Thank you for the invitation.
Thanks so much.
Thank you.
And Tony, thank you so much also for being with us. I think it's been a huge pleasure. I think, as you just mentioned, clinicians are the key point. Probably we still have a great or huge amount of work to do in developing the metrics for the different procedures, validating them, which is not, as you said, a simple task. and then doing those randomized clinical trials in which we really demonstrate that those metrics do really have an impact in clinical outcomes. I think all those tasks are missing.
Yeah, I mean, medicine, they think there's something omnipotent about the metrics. There isn't. I mean, I think you worked that one out when we were working together to develop the metrics for the low anterior. But your starting point has to be clinicians who are good at the procedure. They don't have to be world class. They don't have to be a big name, but they absolutely have to be good at the procedure. And it's better if they understand what it is that they want the trainee to do. They can't expect the trainee to perform at the same level or to be able to do the same things or to use the same approach as somebody that's been doing it for a number of years. But once you, I mean, you, Marcus, or you, Klaus and Mark and Sam, I would expect you to develop the metrics for another procedure in a fraction of the time that it took us to develop the low anterior section metric. So what needs to happen within the societies is you need, like the guidelines panels, I think you're going to have to develop metrics panels where you have individuals, cohorts, that are developing the metrics for a reference approach to the performance of certain index procedures that you expect the trainee to be able to do by the end of their either their residency or their introduction to a new technology such as robotics. And that you also need to develop the benchmarks that the societies own, that the benchmarks are based on the objectively assessed performance of your members, so that you own the metrics and you own the benchmarks. And but that introduces curveballs. I'll get to those in a minute. Once you have the metrics, you basically have the foundations, and it's then what you want to do with it. Okay, you have benchmarks, so you have the metrics and you have benchmarks for the performance of a procedure. You then know whether the introduction of a new device facilitates the achievement of those benchmarks. You know which errors are most common in the performance of those procedures, so you can actually remediate many of those before they ever get to the trainees get to clinical practice. So it has all sorts of implications, but there's a downside to that. And I'm not too sure that medicine has grasped it. And there's certain, I talked at a Swedish conference last summer, and there was a girl on before me. She was an orthopedic surgeon. She just finished her PhD. And she said, there are certain individuals in my hospital that I would not allow one of my relatives to be looked after by. Okay. Oh, she knew that qualitatively. Once you have the metrics, you can probably identify those individuals quantitatively. Now, what are you going to do with that? And if you have the metrics and you're able to identify these individuals, on a quantitative basis, what happens to them? I mean, is the hospital, do they want to know something? Does your credentialing body within your country? There's ramifications for those. Now, that's not the reason I'm into this. I developed the metrics a long time ago to basically improve training performance. But we're now seeing individuals who perform, we can quantitatively demonstrate, perform worse than the worst trainee. Now, explain that.
At the end of the day, I think what we are willing to do here, or what we are willing to the point we are willing to get is that we have less and less individuals like that, and probably, of course, those individuals haven't had the opportunity to go through a proficiency-based progression metric training pathway. Maybe that we will have to be, let's say, a bit soft with them because they were not lucky enough to go through a proper training. We might just want to offer them retraining, and hopefully in the future, in 10, 15, 20 years time, when we have trained the trainees, the new surgeons through this methodology, which adds a value, we will have less and less people like that. So I mean, I agree that this opens probably the Pandora's box, but it's for a period of time. Say we will have to live with that. Otherwise, I think it doesn't make sense. And I mean, on top of that, we should all be happy of, at the end of the day, we are all going to be patients at some time, and we at some point, and we should be happy of having surgeons that have gone through proper training, that have gone through assessment, and that have reached a level of proficiency. So I see the point, but it's something we have to accept, I think, or we should accept.
Yeah, I mean, it's my experience that the vast majority of surgeons, if you give them objective performance feedback, they'll take that on board. There was a guy, I talked at a European Surgical Association meeting quite a few years ago, and they were presenting the preliminary results from the Berkmar study. And there was a guy, I mean, you know, at the European Surgical, you present your data and then your question for about 10 or 15 minutes, and everything's reported. Anyway, this guy, he reported the Berkmar data, the results were impressive. And you can imagine some of the old guard in the room, and asked him his question. And one of them said, he said, were you in the study? And he said, yes. And I said, were you above the median or the mean or below the mean? He said, I was below. And I said, what did you do? He says, I took courses, I took mentoring, and I made damn sure I got above the mean. And I thought that was a very honest answer. And I mean, to be honest with you, I would have expected nothing less from a surgeon. But you're going to have a core there. And I totally agree that don't want to hear it or don't improve. And I totally agree with you. The individuals like that, they didn't come into medicine with those rules. And the rules probably have suddenly changed. And I do think that there should be a softer approach. But you still have to be cognizant, you know, of those individuals and what you let them do.
I agree, and that makes that this has real life consequences, I would say. But again, I think is the way it is.
Yeah.
There was a question in the chat box made by Sarah Ballestero. She was asking about, I think probably the profile of people that should be involved in developing the metrics. She was saying, what do you mean with sense of humor? Probably about the let's say the psychological profile of the people that would be involved in developing the metrics. And I don't know if you can further comment on that.
Yeah. I mean, I'm ideally, I mean, the number one, you need to get into the group, in my opinion, you've got to be good at what you do. I don't mean brilliant, but you got to be good at what you do, and you've got to be able to self-reflect on what it is that you do. And you've got to be able to identify. There was a friend of mine, he'd just back from holidays in France. He'd spent 3 weeks and probably quite a bit of wine during the 3 weeks. And he came back and he was operating his first day back. And I was meeting him that evening. And he's a thoracic surgeon. I was meeting him that evening to sign off on a paper. And he came in. He says, Tony, give me a drink quick there. And I says, why, what's wrong, Jim? He says, I'm just back from holidays. He said, I wasn't very good today. And he says, the guy that was with me was even worse. But Jim's, it wasn't very good, would have been brilliant. Jim he's a fabulous surgeon to us. But Jim had that capacity to self-reflect in a humorous way. And I think if you're developing the metrics with individuals that take themselves too seriously, it becomes very hard work. It almost becomes like therapy. And I mean, you know what we were like. I mean, we laughed at things we probably shouldn't have laughed at, but we were still able to knuckle down and identify things that maybe started off being humorous, but actually touched on an important point. You want individuals like that. And I suppose, I mean, individuals that are comfortable inside their own skin, that are happy to tell you about something they maybe didn't do so well and the lessons that they learned from it. Years ago, I was characterizing a CRT implantation, and we had a very experienced German clinician who had an academic appointment, but wasn't really an academic. We had a young Lebanese cardiologist who was very good, very talented. And we had an English professor of cardiology. I mean, anyway, the English cardiologist who's head of department and all the rest of it, he was showing how he anesthetized the chest wall to create the pocket. And he was making multiple punctures, demonstrating multiple punctures. The German guy stopped him. He says, "What are you doing?" He said, "Well, I'm making sure that the chest wall is anesthetized." And the German guy says, "That's not what you do." He says, "You make 1 or 2 punctures and you move the needle around." He says, "You don't make multiple punctures." And the English professor was looking at me saying, he says, "But that's the way I've always done it." And you could see he was maybe starting to get slightly cross. And the German guy said to him, he said, "Why do you only make a couple of punctures? Or sorry, what's the most common reason for a CRT or pacemaker failing?" Pocket infection. The English professor sat back in his chair. I had no idea what he was going to do. He said, "I never even thought about it." And we were in the bar later on, and he said he changed his practice on the spot. What that told me was that guy was very comfortable in his own skin. And when he heard something and recognized in his practice, I mean, is it a huge deal? Probably not. But he recognized something. And those are the sorts of individuals that you want for a characterization. If you can imagine, like if Klaus and Sam and were as serious as you.
No, I agree. I think it's a question that the people probably would all have, and as we think that developing metrics will be hopefully in the near future, but I think it really will more and more common. I think that's something that we will probably all have in our minds, or the ones that have less experience with this will have questions like how do we do this? I think right now that I've personally gone through the process of developing the robotic assisted LAR metrics, I probably would feel, as you said, comfortable with developing new metrics and probably would get into them quite fast. But first time we did this, I honestly would say that it looked to me like an impossible endeavor. Like it was going to be quite no. I mean, honestly, we all have a clinical background. We all have our clinical knowledge, but I think very few of us do have knowledge in developing metrics or in training or in other kind of skills. And I think that this is why, for most of us, this is or looks like a huge endeavor, like a very complex one, and that if we don't have someone that is experienced like we had in our case, was just you, which was a privilege. I think that would be probably something that for most of the people would be kind of like a no-go. They would feel like they are lost in developing metrics.
Yeah, I think the first time that you do it, you really do need a guide. I mean, Rick Angelo, he describes it very well. I mean, Anna's study worked so well because I gave them advice and they took it. A lot of the times, I mean, I give advice and it's ignored. But once you've done it once, I mean, at Yale was the first time we used the procedure characterization to develop the metrics for a lap chole. And for part of the lap chole, it took us about 6 months to demonstrate or to develop the metrics. And the second procedure we did on a Friday afternoon, because the surgeon had learned the process, and it's about learning the process. It's about the thinking. It's about how to define rather than describe. It's about the explicitness. It's about the direction of the wording. It's about the understanding that an error is probably not, the way that you would normally think about an error. An error is something that, okay, it's something that the surgeon really shouldn't be doing. Is it going to be critical? We don't know. And a critical error, I think you do understand. Once people go through that, I think that they're well up their learning curve. It's then down to the detail. I mean, I still help Rick Angelo and guys like that. And it's more the quality assuring and nudging them back on track when they start to deviate a little. But Alex has been trying to persuade me to produce a few more guys like me. And I've told him no. I said, I'd prefer to train the clinicians to do this because the clinicians have to take ownership. They have to take it inside their societies. They have to own the process. You know, I mean, and you have 3 now within the CP.
Yeah, agree. I think it's it's another skill that some of us would need to learn and to implement. I think. And as we all, as you know, and I think I also would like to share this with the people listening us today. I think learning these skills really helped. I think me and the rest of the people I shared these skills with, like, you know them, like Ahmed or Lidia Cristobal, while working together. I think for all of us, it was really an experience that helped us do what we were doing. I think that in a better way, just by learning the skills, because we were, I think, more conscious of the steps we need to follow during a procedure, and we were more conscious of the errors or the critical errors we could do. So I think that this has a lot of side effects, positive side effects, I would say. And this is why I think we wanted also to invite you today to this forum, and to try to expand the knowledge as much as possible.
Yeah, Ruben de Groot was he was a fellow in London. He's now a consultant at OLB. Ruben was one of the guys that assessed the prostatectomy metric. I'd never met Ruben before. He got the PBP lectures and so on. But Ruben, along with another consultant, did the assessments of the metrics. And I was listening to him talking to somebody one night, and he said that he was describing the PBP process, and he said that it had changed how he understood learning a new procedure, the structure that he imposed. It changed the way that he communicated to the residents and the fellows how you actually perform. And it's altered. It's made him more acutely aware of the things that he does well and the things that he does less well. But I mean, it has focused his attention in, and he's successfully applying that now to other procedures. And what Alex tells me is his learning curve is accelerating hugely.
Yeah, one example we use here internally, and I think it quite represents quite well what this is that you've been probably cooking a recipe for all your life, and you think you are good at doing it, and the food tastes excellent and everybody's happy about it. But when they tell you how do you do it, you just say, well, I don't know, I just do it this way. But how much salt are you using? Well, I don't know, a little bit. And sugar, well, another little bit. And eggs, well, a few. And this, I mean, having the metrics is just knowing that you need to use 20 grams of sugar, 25 grams of salt, 2 eggs, and that you have to put them in this order, and that the time of cooking is not just about half an hour, it's just 35 minutes. And I think this is what metrics give the surgeon, that, and once you know all those measures, you really are aware of, and if you say, well, do you put them always in the same order? Well, I don't know, I think I do it that way, but I don't really know. And with metrics, you really know that you have to use salt first, then sugar, then the eggs. And that, I mean, it's probably a silly example, but at the end of the day, I think represents what metrics can really give clinicians and how they can really improve what we do.
Yeah, I mean, and it allows you to pass on the wisdom that you have accumulated over 20 or 30 years. I mean, in a relatively compact, time frame, where in the past you taught that apprenticeship style. And apprenticeship style is, I mean, it's still going to be there, but I think
it works. But
but you're going to compress the learning time. I think that a lot of the numbers that are being used for competencies are they're plucked out of the air, they're statistical aberrations. I think, once you have proficiency benchmarks, that's going to accelerate and compress, the performance variability of graduating residents once this is implemented, on a wider base. The other thing that we've discovered, we did a study last summer during lockdown on telementoring using the metrics. And one of the things that kind of shocked us was that we thought that the telementoring of the robotic surgical skills would be the equivalent, or certainly not worse than the training in the skills laboratory. Now, this is just for the robotic suturing and anastomosis task. What we found was that with the metrics, it accelerated the learning curve of the trainees enormously, and they were getting to proficiency faster than the trainees in the skills laboratory. Now, number one, I want to verify that, but I'm of the view that if the scientific methodology is good and robust, you can't ignore the data. What I'm interested to know now, which hopefully we'll look at later this year, okay, does that apply to procedural learning as well? You know, if you're supporting somebody rather than standing beside them in the OR, if they have the metrics that you've trained them to proficiency in the skills laboratory on the procedure, and what's the difference between the surgeon standing beside them in the OR or being available to them in real time with telestration capability? And it's down to the metrics.
Yeah, I think if you have the right methodology, probably at the end of the day, that's the key point. And then you have probably different tools, I mean, as we spoke about physical simulators, you can have virtual reality simulators, you can have just probably the most cost efficient ones, but at the end of the day, they have to be built based on those metrics. Yeah. There's a question from Samuel Reñosa talking about the kinetics, haptics, force feedback. Which is your view on that? Do you think that those are key points or are important points for training?
They're important points, but they're not at this period of time. And the simulation industry is going about it the wrong way, because, I mean, what we feel at the ends of our fingertips or wrists or arms and so on is different to every individual. And if you go, say, for example, do a laparoscopic task, and then you go for a run and you come back again, the physical force feedback and tactile sensations that you receive will be entirely different before you went from a run and after you come back from the run. And there is no attempt within the simulation industry to individualize the haptic and tactile feedback that the surgeon gets. A lot of it's just that they feel something, and I'm not a great fan of that. That's to be quite frank with you.
I would agree with you. I mean, I think that the current simulators are a bit kind of looking to probably the wrong place, or the wrong direction. But we'll see if that changes in the next few years, hopefully.
Yeah, I mean, the amount of money that a robot costs, I think the level of simulation fidelity that's currently available is less than satisfactory.
And the expansion that robotic surgery is having probably would justify the
correct. That's correct. I mean, it's the market that's driving the physics-based virtual reality simulation for endovascular procedure. I mean, it's the real business. You're using the real devices. You more or less feel what you feel at the end of the catheter and wire that you would in a real patient. No surgical simulation is even close to that. And the robotics, I agree with you, the market's there, but there doesn't seem to be the effort to actually increase that fidelity for the surgeons. I have absolutely no idea why.
Thank you so much, Tony. I think we can close the discussion. It was a great pleasure for all of us. Thank you also, Roberto Ballestero, for being with us this evening. And again, Thank you so much, Tony, and hope that well, we gave a good overview of physical simulators of the proficiency-based progression methodology, and well, hope that the full 3-day series of this robotic surgery forum were interesting, and that you saw new things, different things, and we were able to stimulate new ideas and potential research projects for all the people that met with us. Again, thank you all for being here, and hope to wish you a very good night and very good weekend. Thank you.
So, bye.
Thank you, Tony.